Hello everybody, my name's Annabel Crabb and I'm here to welcome you to the Breast Cancer Trials Q&A on the topic of breast cancer recurrence. And first, can I just say that there are so many of you who have signed in and asked questions for this session. I've done, I think, 3 of these sessions now with breast cancer trials, and I'm overwhelmed with the degree of curiosity and interest and attention that there is out there for answers from experts, and I'm very pleased that we've got a great panel to talk to you tonight. I would like to acknowledge to begin the traditional owners of the land from which I'm shakily broadcasting you a couple of weeks into an election campaign. I'm here in Marrickville, New South Wales. It's raining outside, but at least there aren't very many planes going over, so double thumbs up. But this is the land of the Gadigal people of the great Eora Nation, a culture with a long and uninterrupted tradition of care, of family, and I would like to acknowledge the traditional owners of this country and the traditional owners, whichever country it is from which you are paying close attention to this session this evening. And kia ora to those joining us from New Zealand, of course. Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978, over the course of which time the experience of those diagnosed with breast cancer has changed beyond recognition. The fear, of course, of breast cancer recurrence is a very real issue faced by anyone diagnosed and successfully treated for breast cancer. Fortunately, Australia and New Zealand have some of the best survival rates of breast cancer in the world, but despite recurrences normally happening within 5 years after the initial treatment, that fear that cancer may return at any time later in life is a super common worry for many people. Breast Cancer Trials wants to ensure that all those people know that they're not alone, and I think just the extent to which people have signed up to this session, there are 2,800 of you online, which is just prodigious, shows just how alive and commanding this anxiety is. So we're looking forward to answering some of your questions on this very important topic. I will say we've had so many questions pre-registered, and they cover a lot of territory, and there have been a lot of questions that have been asked by a lot of people. So we've scanned the questions and we've collected a cross-section that we think really fully represents the span of concerns that you've come forward with. So if you hear your question being named, being asked under another name, it's because we just picked one that represented that group of particular concern. I'd like to introduce the panel. Again, a terrific expert guest panel who'll be answering all your questions around breast cancer recurrence this evening. First of all, Ms. Leslie Gillum, who's the chair of the Breast Cancer Trials Consumer Advisory Panel. She was a participant in the TEXT clinical trial, so can bring a significant personal range of experiences to answer your questions tonight. Professor Shireen Loy is the head of the Translational Breast Cancer Genomics and Therapeutics Laboratory. She's a medical oncologist in the breast service, the head of the Breast Cancer Clinical Trials Unit at the Peter MacCallum Cancer Centre. We're very, very pleased to have Professor Loy with us this evening. Professor Prue Francis is the head of medical oncology in the breast service at the Peter MacCallum Cancer Centre and a consultant medical oncologist at St Vincent's Hospital in Melbourne. And finally, Associate Professor Leslie Stafford is a clinical psychologist and consults in the breast service and familial cancer centre at the Royal Melbourne Hospital, as well as in practice. And Leslie is an associate professor at the University of Melbourne. Every time I introduce our expert panel at these events, I always feel just horribly underqualified and also ill-equipped really to understand the nature of the material at hand. But hey, that's what journalists are all about. We are professional ignoramuses who are happy to ask stupid questions, because that way you learn more. And I guarantee you, I will never overstate my degree of expertise in this field to any of you watching. We've got experts gathered for that, for the purpose of enriching us, and I absolutely propose to get amongst it. Right. Thank you, everybody who submitted questions for the Q&A. It has been a huge response, as I said, and we've had more people to register for this topic than any other that we've ever held before, including the sex one. So how about that? Right. We do have a little bit, just to get an idea of the scope of the questions that you all asked. We've got a little bit of a sample crunched into a video that I think we can take a quick look at now. So I think you've got an idea there of the degree of interest and the degree of concern about this question of breast cancer recurrence. And before we get into the clinical detail of what that involves, I thought it'd be a good place to start by discussing the question of fear of recurrence, which is a really significant part of a lot of breast cancer survivors' lives, right? And I'm going to go first. I'll be going one after the other to each of our panelists. So if you think I'm terribly rude for not having thrown a question to Prue yet, don't worry. We're going to have plenty of questions for all of our panelists. But I wanted to go first to Associate Professor Leslie Stafford, who's a clinical psychologist and consults in the Breast Service and Familial Cancer Centre at the Royal Melbourne Hospital. She's also an Associate Professor at the University of Melbourne. Leslie, if we can start with you and a really, really general question, why is the fear of breast cancer coming back so common, and what are the fears that you hear most about in practice?
Thanks, Annabel. Look, it is a very common concern, and I would say it's probably one of the main reasons that women will come and see me in the clinic. And we have to remember that it's a very rational concern. There is no test that can guarantee you with 100% certainty that you will never have. And so the fears of recurrence that we see in the clinic exist on a continuum. Most people will have some worries to some degree and experience these thoughts sort of occasionally, and then you have people with more moderate worries, and then the ones with more severe thoughts about recurrence that often happen in the absence of triggers. They feel that they can't sort of control their thoughts. These are the people who are often over-monitoring for signs of activity, searching online, and often wanting reassurance. So what do women say that talks to their fear of recurrence. So the fear often tends to set in towards the end of active treatment and sort of the start of survivorship, when women are no longer having as frequent contact with the treatment team. And women are often unsure of sort of who to ask and what their symptoms mean. Some women will say or express a worry that because they're not on active treatment, they're not doing enough to manage their cancer. And they're anxious because they want proof that the treatment has worked. I think for older women, particularly who were asymptomatic and whose breast cancer was detected on breast screen, there's that sort of niggling worry that you didn't have symptoms in the first place. So how would you know if you had a recurrence, and will the scan pick it up on time? I guess for younger women, the fit, young, healthy women, they can often feel like their bodies have really let them down. They've eaten well, smoked, and yet, they still have breast cancer. So if that wasn't enough, what does it mean for the future? And these women often feel quite lonely and misunderstood because there is an expectation that they should have moved on or bounced back. But they're really worried. So I guess, underlying this fear of recurrence is often the fear that if the cancer comes back, it's not going to be a local recurrence that you could manage. It's going to be a cancer that has spread, a cancer that you're going to die from. And that sort of leads to worries about how you might die and how your death would affect your loved ones, particularly young people. But then there's also the underlying thought about, well, if I had a recurrence, I don't know that I have it in me to go through all of this again. And your motivation to do that might be a bit low, given that you've had a recurrence. Women just can't face that disruption. And I'll just say one more thing, because I realise I don't have a great deal of time, but it's really difficult to combat this because it's triggered in so many ways. You go down to the shopping centre and there are pink ribbons. So it's really hard not to think about it. Women need to look down at their breasts every day and be reminded. 1 in 7 of us will have breast cancer. So it's really hard to avoid it, and social media is quite awash with unhelpful triggers and catastrophic stories.
Leslie, so often, we pathologise cancer as a battle. You'll fight this, and it's almost as though there's this sort of cancer as an aggressor against which someone with a diagnosis has to be vigilant and to be a fighter. But after treatment, it's almost as though you have the fear but not the battle, right? And so is it common for women to lapse into a feeling that, they're vulnerable because they're not fighting anymore?
I think this whole language around battles and fighting and you can beat this, it's very unfair because it assumes a level playing field. And so when cancer does recur, it invites the kind of questioning like, did I not fight hard enough? Was I weak? Did I do something wrong? And we do tend to live in this sort of obsessional kind of state around being positive and looking on the bright side and taking control of your behaviours, and that's not always possible. What happens if you aren't exercising 3 times a week? What happens if you aren't eating healthy? Are you then responsible for bringing back your cancer?
So Leslie, obviously we know that a recurrence of breast cancer is more likely to occur within the first 5 years after treatment. What have you seen about the profile of that fear and anxiety up to that 5-year window and beyond?
So look, women do attach a lot of significance to the 5-year mark, and it's not uncommon, I guess, during that time to see women living scan to scan, and hopefully magically at 5 years their worries will disappear. And then, of course, they're surprised and disappointed and worried when it's still there at 5 years. So anecdotally, women who've been disease-free for a long time say that the worries do recede and it does become easier. But you have to remember that in the clinic, I'm not seeing those women. I'm seeing the women who are struggling. And the research tells us quite clearly that fear of cancer recurrence is stable over time. So that's not to say that you're not going to have peaks and troughs that might sort of heighten around scans or anniversaries or the diagnosis of a friend or so on. But it means that in general, if your fears of recurrence are low, they'll stay low. And if you have high or severe levels of fear, then it's best to get help sooner rather than later, because severe fears don't get better on their own.
Leslie, we've got a question here from Kristen, who I'm sure would be speaking with and for a lot of our women who have dialed in today. She says, what advice do you have on what strategies I can use when people say, oh, you'll be right, you'll be fine?
And look, again, I hear this so often in the clinic, so I'm not surprised that this is a sort of one of the frequently asked questions. So other versions of this are, well, just think happy thoughts, or stay positive, or look on the bright side, or don't worry about it. And there are all these cliches and platitudes that can really get you down. Real pressure to be triumphant and back to your own old self, when in reality you can feel quite alone or quite scared or worried or even traumatized. And I guess it's sort of easy to understand the motivation behind these responses. We are in a culture that's uncomfortable with grief and suffering, and the normal human response is to try and make that better. So people sometimes forget that the real path to better is going through difficult feelings rather than skirting around them. And, you know, as I said before, we have this kind of cultural obsession with positive thinking and the need to put positive spins on everything, even when it's actually profoundly tragic. So it's important not to ignore your feelings or not to not talk about them, because that's actually cruel. And when people say things like, you'll be right, or you'll bounce back, or just put it behind you, that minimizes and invalidates our experience. So what can you do? Well, I think you can know that being positive doesn't actually directly change the course of your cancer or necessarily lead you to live a longer life. It is associated with a better quality of life. But if you're not positive all the time, you're not inviting a poorer prognosis. And I think that's important to know. I'd say you need to be realistic about your emotions. Your emotions are valid. You need to honor them. You need to accept them. I would suggest limiting your exposure to people who invalidate your feelings. And it's difficult to call out this kind of toxic positivity because positivity is thought to be such a good thing. But you do need to call it out. And you might say, hey, you know, instead of saying you'll be fine, it would be really helpful for you to recognize that actually it's okay for me to feel bad sometimes. And maybe you could say, gee, I know things are really tough, but I'm here for you. Or something like, I can see that, you know, this is a really challenging situation for you. Let's see if we can make some sense of it. I also strongly encourage women to take a break from social media, where, you know, you need to be your sort of hashtag best self at all times. Puts a lot of pressure on you, and that's not helpful. And then I guess finally, some women will identify this kind of positive, toxic positivity in themselves. And that's probably a learned behaviour or a behaviour that women have to protect themselves. So in these instances, I would suggest writing in a journal to explore your thoughts and feelings, And, come from a place of self-acceptance. Be curious with yourself about what's behind this sort of unhealthy positive thinking.
Thank you so much, Leslie, and I personally feel empowered to strike a blow against toxic positivity sometime very soon. Luckily, there's not a massive amount of it on display in the election campaign, which is what I'm currently engaged in, but those are valuable tools. I'm going to move on now to Professor Prue Francis, who of course is the head of medical oncology in the breast service at Peter Mac Cancer Centre and a consultant medical oncologist at St Vincent's Hospital in Melbourne. Prue, Vicky has written in and has, really asked a very easy to answer question, which is, why does breast cancer come back?
Thank you, Annabel, and thank you, Vicky, for the question. So breast cancer can sometimes come back locally in the breast, which was operated on. And in that situation, there were perhaps already some microscopic cancer cells in another part of the breast, or some precancerous cells in another part of the breast or nearby, and those cells weren't fully taken care of by the radiation and or the hormone therapy that was given. Now, if the recurrence is only in the breast, then that can still be managed by surgery, so that's still something that's salvageable. But perhaps the recurrence that is most feared is a distant recurrence where breast cancer occurs in a place far away from the breast that's not able to be managed by surgery, for example, in the bones or another organ. And in this situation, we think that the cells had actually moved from the breast cancer before the patient really was diagnosed, that they'd already escaped from the breast and they were lying dormant in some other part of the body. And then the drug therapies that may have been given after, the breast cancer was diagnosed have not managed to fully eradicate those cells. And whether that's because those cells had an aggressive behaviour and that was nothing to do with the patient, they just were unlucky enough to get a cancer that behaved aggressively and the cells were not sensitive to the drugs that the patient received, or perhaps the cells somehow were hidden in a dormant way and so they weren't, able to be reached somehow by the drugs. But we think it's really just a situation often of the luck of the draw that those particular cells were not sensitive to the current therapies that we have available.
There are questions thick and fast in this particular division to be directed to you, Prue, and very understandably, there have been a couple of questions about what subtypes of breast cancer are most likely to recur. That is from Jenny, and Catherine has asked also if rates are higher for those with triple negative breast cancer.
Right, so I guess broadly speaking, we think of three subtypes of breast cancer. We think of the hormone receptor positive or estrogen receptor positive breast cancer, which is HER2 negative, and then we think of triple negative breast cancer where there's no hormone receptors and no HER2 overexpression, and then we think of HER2 positive breast cancer. So three sort of common subgroups, I suppose. And if we think of in the clinic, which patients are we seeing most frequently in the clinic, numerically there are more patients with hormone receptor positive or estrogen receptor positive breast cancer in the clinic that have a recurrence, but that's partly a reflection of the fact that that is the most common subtype of breast cancer. And so that's why we see more of those women, because it's the most frequent type of breast cancer. With the question about triple negative breast cancer, it's true that there is a concern that this is a subtype that can recur at a rate that remains concerning to medical oncologists and to patients. And it's a very active area of research to try to improve the outcomes for triple negative. But it's also important to remember that the majority of women with triple negative breast cancer originally diagnosed with it, if it hasn't already spread at the time of diagnosis, the majority can still be cured, even though there will be patients with triple-negative breast cancer who do experience a recurrence.
Thanks, Prue. Trish has asked whether recurrence is more common in a particular demographic.
So I guess thinking of demographics, some of the ones that we over time have been concerned about are very young women with estrogen receptor positive or hormone receptor positive breast cancer. And, you know, from data that we had going back several decades, that was a group that we did worry about because they seemed to have a higher recurrence rate than older women with estrogen receptor positive breast cancer. So the very young has been one focus of research to try to to lower the recurrence rate. I guess if we're thinking about demographics, I suppose, you know, there is some evidence that will tell us that women with a high body mass index have a slightly increased risk for recurrence. Now, obviously, that's at the time you're diagnosed, so you have the body mass index that you have when you're diagnosed, so it's no good going home and thinking, well, there's nothing, you know, that I can do. But we know that can be a risk factor, but you shouldn't, again, blame yourself about that, and it doesn't mean that your cancer will come back. So that's another demographic. And then sometimes we look at demographics where patients have had preoperative drug therapy and have had very little response of the drug therapy, you know, with the cancer, if it's a triple-negative breast cancer, if it's had very little shrinkage, we are sometimes concerned in that demographic.
Thank you, Prue, for answering these questions so clearly. I know that this is going to be a significant assistance to everybody watching in. I've got one last question for this bracket for you from Louise, who asks, why is it that 5 years is the marker for recurrence and taking medications like tamoxifen when cancer can still return after 5 years?
So I guess when we started out with hormone therapies like tamoxifen, we did clinical trials and breast cancer trials. This group is known for doing clinical trials. And so originally tamoxifen, when it was given for a year. Then there were trials showing that 2 years was better than 1 year. And then there were trials showing that 5 years was better in terms of reducing recurrence than 2 years. So for a long time, 5 years was the standard duration of post-operative hormone therapy, and that so became a time point at which women were often discharged from medical oncology follow-up and perhaps from surgical follow-up because it was a sort of a 5-year hormone treatment. But we recognise that that is not the only time when cancer can recur. And in an oncologist's mind now, we know that sometimes we will be extending hormone therapy beyond the 5-year mark. And we also know that different subtypes of breast cancer have different times when they're more likely to recur. So for example, while triple-negative breast cancer patients may be alarmed to be diagnosed with that, in fact, their peak time of recurrence is over after about 2 or 3 years. That's their riskiest time. And whereas a patient with hormone receptor positive or estrogen receptor positive breast cancer has risk after the 5-year mark, which is greater than a patient with triple-negative breast cancer. So the recurrence time can vary according to your subtype of breast cancer.
Right, okay. Thank you, Prue. I'm going to leave you there and I'll come back to you in a little bit because I'm going to now direct some questions to Professor Shireen Loy, who, as you'll recall, is the head of the Translational Breast Cancer Genomics and Therapeutics Laboratory. She's a medical oncologist in the breast service and head of the Breast Cancer Clinical Trials Unit at the Peter MacCallum Cancer Centre. Great to have you with us, Shireen. First up, we've got a question from Michelle, who says, what is the most common place in the body for breast cancer to come back?
Thanks, Annabel. Hi, everyone. Nice to be here with you all. So this is also a very common question. And the first thing to say is over 90% of women are alive and breast cancer free at 5 years. So we have excellent survival in Australia for women with breast cancer who receive appropriate treatment. So that's one thing to emphasise. Most women will never see their breast cancer come back. But if it does come back, the most common place it will come back is meant to be in the bones. And then after that, perhaps in lung and in liver. We don't really know why breast cancer cells like hanging out in your bones, but it could be just because we have a lot of bones, right? So it's just a chance that some of the cells might be lodged in that area. And there's constant turnover in the bone because you're always like shedding bone or making bone. So it's quite possible that that process also encourages cancer cells to grow. So a bit of fertilizer in that particular area. But yeah, the bottom line is we don't really understand why some people's breast cancer cells like certain parts of their body.
Thank you. We've got a question from Therese who asks, when a breast cancer returns, is it a new cancer or is it always related to the original one?
Yeah, so when we have a suspicion of that, we almost 100% try to take a new biopsy to try and accurately determine that. We may be able to guess because we have features of the early breast cancer, the size, or if there are many nodes involved, or the subtype, which may increase the probability that a breast cancer has returned. But generally the gold standard is the biopsy, and that's because now we have lots of special tests that we can perform on a fresh biopsy to try and help us understand what's come back and the best treatment for that patient.
Does it matter? Sorry, if that's a stupid question, that is, to be clear, my stupid question, not Therese's, but does it make a difference if it's a new one or the original one?
Yeah, it's a great question. So I think if it comes back in the breast, we can still manage it with a very good chance of curing that patient again from that breast cancer, similar if it's in the lymph nodes. If it's outside of the breast area, then it does make a difference whether it is a breast cancer recurrence or whether it may be another new type of cancer or something that's completely unrelated. So it's very important to have a new biopsy.
Okay. Got a question now from Lisa, who's asked, and I'm sure that this will be a question on the lips of many, can you determine what your chance of recurrence is of breast cancer through genetic testing?
Yeah, so the question is related to whether we can try and predict if a breast cancer will come back related on the tumour biology or the genes that make up a breast cancer. So there is some genes that are inherited in the family and that predispose some women to a higher risk of breast cancer. But that gene, such as the BRCA gene, doesn't necessarily mean that you have a higher chance of your breast cancer coming back. In fact, we know that that gene makes you particularly sensitive to certain treatments. So actually that is a positive, that we have very precise and targeted treatments now to certain genetic mutations. There are some assays that we can have a look specifically at the tumour makeup to try and understand if it's a very aggressive type of cancer or not, and that might help us guide treatment decisions about, for example, chemotherapy, what type of chemotherapy and how much to give in some women. But that's not, of course, in everybody, and everyone's case has to be individualised.
Of course. I've got a question from Faye who says, what priority would you put on risk assessment and earlier detection, and why?
So earlier detection of breast cancer is, of course, the holy grail because we know if we detect it earlier, there is a higher chance of cure. At the moment, we use things such as mammograms in older women and MRIs in younger women who have maybe a family history. So there is a lot of research at the moment to try and develop better tests to pick up breast cancer earlier, particularly in blood. We call them liquid biopsies, but we have to really wait for the technology to get very sensitive because, as you can imagine, picking up tiny little cells in the blood is very, very difficult, but there's a lot of research with regards to that. When we see a person diagnosed with breast cancer, there are certain things about the features of their breast cancer that may make us more or less worried. But once we prescribe the treatment, and the surgery and the radiation, etc. It's kind of a journey that the patient goes through. They complete that, and then we hope that it's done the trick. And generally it has worked in most women. So I think the most important thing is to have the correct treatment prescribed and to also be compliant with that treatment, because, for example, we know that many women don't take the endocrine therapy tablets for, every day, or they skip days, or they stop taking it for a year, etc. So we know that's also really important as well. So I think early detection ultimately will be important, but just not today.
Okay. I'm going to, thank you very much, Shireen. I am going to move now to Leslie Gillum, our second, but by no means the lesser Leslie of the panel. Leslie's the chair of the Breast Cancer Trials Consumer Advisory Panel, and she was a participant in the TEXT clinical trial, which we'll hear about in a minute. But firstly, Leslie, and welcome, I'd really like for you to tell us about your experience of breast cancer and when and how you were first diagnosed.
Thanks, Annabel. Hello, everyone. Thanks for having me. So I guess if I think back, I was diagnosed back in 2009 with breast cancer, with ER positive, HER2 negative lobular breast cancer. And it sort of came about, I was considered young at the time, at the age of 45, and it sort of came about because I was supporting a friend who was going for a mammogram. Didn't think we were in that age group as yet. So when I got home that day, I did a breast examination and found, I guess, what was a thickening rather than, they often refer to like a pea size lump or things like that, but it was more like a thickening. And I just sort of had this sort of feeling that it might not be right. So I went off to my GP. She wasn't overly concerned, but just to reassure me, sent me off for some tests. So originally I had mammogram and ultrasound, and then it came back as a positive result. Not positive in a good way, positive in breast cancer way. And then I was referred off to a breast surgeon, and I guess that's where sort of the whirlwind started. I'm sure a lot of people watching can understand that feeling when you have that diagnosis. So I was referred to a breast surgeon, more testing, MRI, which Shireen just touched on, probably because of my age. And then what started off as 2 small tumours, I ended up with 5 tumours. And then I underwent mastectomy, chemotherapy, radiation therapy, and as you mentioned, I was a participant in the clinical trial. So I was on 5 years of an aromatase inhibitor, and then a breast reconstruction with a DF flap followed on after all of that. I think it was all about 2 years, the whole process.
Wow. I bet that there are plenty of people watching who are kind of emoting with you and your experience going through all of that. And I'm struck by this sense of kinetic activity, right? Like all of a sudden one thing happens and you're thrown into this tumultuous world of uncertainty and looking for expertise and not knowing where to look or whether you're asking the right people, just this sort of new world of uncertainty that you inhabit and the promise of more uncertainty to come. More than 10 years after your own diagnosis, Leslie, how do you think about it now? I mean, how often do you still think about breast cancer and the question of whether it will come back?
Well, I think if I think back, the worst day is the day of your diagnosis, and from there it's a learning curve, and you're provided with information about your personal diagnosis and what you can do in that treatment phase. But I think moving on after the treatment phase, I think Leslie Stafford, I don't want to get confused, touched on it earlier, that once you leave that treatment phase and that, you're referred back to your GP for follow-up and things like that, you sort of get a bit lost. So I guess there's not a day that you don't think of it in some way, I don't believe. I'm a very practical person, and it's still, there's still a number of triggers that remind you of the diagnosis all the time, whether it's a side effect that I'm sure a lot of people out there can relate to are ongoing, whether it's the physical scar. I'm involved in advocacy work, obviously, for BCT, so that's a constant reminder, but it's also a reassurance. And I think, there's like TV, social media, the Mother's Day classics were just held. Yeah. There's all those sort of impacts, but also just seeing my children and thinking back to when I was diagnosed, but it's just seeing them all the time and reminding you that you want to be here for them. So I think there's just constant reminders all the time. Your life's never the same after a diagnosis, but there's just these constant reminders, I think, on a daily basis. They do get easier to deal with, but they're always there.
Leslie, I'm just so struck immediately by what you said when you began to answer that question about the worst day being the first day. And I'm sure, that won't be the same for everybody, but that sense of being at the beginning of a journey of acquisition of knowledge. I mean, if uncertainty is the enemy and the most frightening thing in this experience, then the more information you have, the more control you feel you regain over the situation, right? And that's why particularly I'm grateful to all four of you for being part of this session this evening. And if you think of those 2,800 women and men who are listening to every word you say, how wonderful to think that you might be lessening the anxiety and giving them more control with every answer that you deliver. So thank you again, all of you, for being here with us. I've got a question about the trial that you participated in, Leslie. It was called Text. Can you tell us a little bit about it and tell us why you decided to participate?
Yes, certainly. So as I mentioned, the worst day was the day of diagnosis, but the second worst day was the day that I left my trial team. Because you become such a good, have such good relationships with the people that are running the trial. So I guess my reason for participating in the trial, I'm one who likes to volunteer for things. And I was fortunate enough to be at a clinic that was involved with clinical trials and clinical trials research. So I know that's not the case for everybody. But my oncologist and surgeon, I guess, were very encouraging about the work that they were doing, and really the role of clinical trials. They explained it to me about how they look to improve outcomes for people that are diagnosed. So the way it was put to me was really informative, and having a daughter, I guess I just wanted to play my part in ensuring that the treatments and outcomes for people post my diagnosis, may somehow be improved if they weren't, anyone was unfortunate enough to be diagnosed. So the Text trial was put to me. It was like the current standard treatment, which was tamoxifen, versus a new treatment that they were investigating, which was exemestane, which is an aromatase inhibitor. So there was a lot to consider. I was provided with all the information, informed consent documents. In my case, I was actually provided with a protocol, which I now understand better now due to my advocacy work, but it was still enough information to make an informed decision. So part of participating in the trial, whether I was going to be, so it was a randomised trial, so I wasn't guaranteed which arm I was going to be on, but I agreed to participate. It meant going through menopause overnight. So I was injected with a drug that put me into menopause. It involved extra appointments, extra screening, but in a way I think it was actually provided me with a more supportive environment to go through my treatment phase, and it just reassured me every step of the way, that I was actually involved in this trial and these people were supporting me for the best outcome. And, at no stage did I regret ever participating in the trial. In fact, I ended up being allocated to the trial arm, and that as a result of the outcome of this trial, that's now the standard of care in postmenopausal women. So I guess I played my small part in achieving that outcome. And I always think that once you've agreed to participate in a trial, you're actually a partner in the research, not just a participant.
That's such an important point, and gosh, there would be plenty of people on this discussion who would know exactly what it means to go through escalated menopause like that. It is absolutely no laughing matter. So I think, well, I personally really admire your sense of community spirit and your desire to make a little bit of a difference for those who might be going through this experience after you, and your continued involvement obviously with the Breast Cancer Trials Consumer Advisory Panel is a demonstration of the depth of that commitment of yours. So thank you from everybody whose mics aren't on who are on this call. I thought this might be a good opportunity actually just to see a little bit of a video because it gives us a bit of information about the text trial in which Leslie participated, but also another clinical trial called the SOFT trial. Now, both of these trials, which were engaged in by similarly public-spirited individuals, produce some great outcomes when it comes to preventing breast cancer coming back for some women. So let's start our next phase of discussion by having a look at a video about these trials.
The SOFT and the TEXT trials were large international randomised trials specific to younger women with breast cancers, and in particular hormone receptor positive or an estrogen receptor positive breast cancer. Very young women had worse outcomes than older women with breast cancer. So the trials were developed to understand if we could suppress the production of estrogen, whether we could actually get a better outcome compared to the standard treatment for these young women. So we had the first results from the trials in 2014. Thus far, we do think this is important information, and it has actually changed practice in many parts of the world. We can see there is a reduction in the recurrence rates. We obviously need to look and see ultimately whether this will improve survival, so we do need longer follow-up. But I think this could be an important first step to trying to improve outcomes for a group of women that we were concerned about previously.
Right, well, that was an illuminating video. I'm just going to go to you now, Francis, for some specific questions about those trials. Could you explain to us, please, in your pellucid manner, why were these research findings so important, and how do they play out naturally the practical effects in terms of treating women today?
Thank you, Annabel. Well, the impetus for doing the SOFT and the TEXT trials was around the observation that very young women diagnosed with these estrogen receptor positive breast cancers had higher recurrence rates. And we were particularly concerned about women who were really young, for example, under 35 years of age. And one of the questions that had long remained unanswered, we know that those very young women in their early 30s or perhaps even in their 20s, even when they have chemotherapy for breast cancer, generally their ovaries will continue to function to the extent that they will still have periods and that they will still produce estrogen each month. And so one of our questions was, does it matter that their ovaries continue every month to produce estrogen if they have a cancer cell that has an estrogen receptor on it? So the SOFT trial was really designed to answer the question, if we could shut off the production of estrogen from a woman whose ovaries were still producing estrogen, could we reduce that recurrence rate, and in particular in those very young women? So that was the SOFT trial. And then we were also looking in the TEXT trial and saying, well, in postmenopausal women, we know that aromatase inhibitor hormonal therapy is a bit more effective than tamoxifen at reducing recurrence. what about if we made a premenopausal woman temporarily postmenopausal? And Leslie may not think that 5 years was very temporary, and I would agree it's not, but in a potentially reversible manner, then could we also get a lower recurrence rate by giving an aromatase inhibitor? So those were the questions we wanted to address. Now, it has changed management for very young women, because nowadays, if you are under 35 and you have an estrogen receptor positive breast cancer, your doctor will be probably talking to you about having your ovaries suppressed as part of your treatment for a few years to try to block that ovarian estrogen production. And we know that that can reduce recurrence in those very young women from the SOFT trial. We also know from the SOFT and the TEX trials that for premenopausal women who have aggressive tumour biology, for example, women who have high-grade tumours or grade 3 tumours, perhaps women with a number of lymph nodes involved, that combination of suppressing the ovaries and using an aromatase inhibitor does appear to be more effective than, for example, tamoxifen alone or tamoxifen with ovarian suppression for reducing recurrence. So I'm not saying every premenopausal woman needs these treatments, ovarian suppression or an aromatase inhibitor added, but there are selected premenopausal women who can reduce their recurrence with more intensive hormone treatment.
Right, okay, so I guess the holy grail of this is how to control the recurrence of breast cancer at the point at which you're administering the initial treatment, right? Like it's trying to kill two birds with one stone, all right? You're eliminating this cancer and as well as decreasing the possibility of recurrence. So are we there yet, I guess is my...
Well, one of the nice things about being old, and I'm one of the old people on the panel in terms of oncology old, I have no idea how old you are, Annabel, but is that I have seen the improvements over time since, I first started training in oncology as a junior oncologist in the 1980s. And at that stage, breast cancer had dreadfully high recurrence rates. And what's happened is that we have incrementally added, one thing on top of another, and we're still adding things and trying to find which patients need which things added, so that at the time that we're treating them, we can try to give them, for example, if they have an aggressive cancer, we're going to think about chemotherapy, but we also want to say, does the cancer have any other targets? Does it have an estrogen receptor? We'll target that. Does it have HER2? We're going to target that. If a patient has a germline mutation, a BRCA1 or 2 mutation, we hope that in the coming period that on the PBS we might have access to new targeted therapies called PARP inhibitors. There are also some cell cycle inhibitors that we may use to reduce recurrence in the future. So we're adding incrementally treatments for selected patients who we feel the risk justifies it.
Right, thank you. That is an incredibly helpful series of answers. I have one more question for you from Priya, who wants to know, and I guess this would be a burning question in the minds of many watching tonight, what research is being done to diagnose recurrence earlier?
Okay, well, it's a complicated question. If you're talking about recurrence in the breast, it is helpful to diagnose it earlier. And so we would be imaging the breast of women who've had breast cancer each year normally, any remaining breast tissue that they have, and we would certainly be examining them in the clinic, and we would like them to contact us in between times if they were aware of any change in their breast. So it is certainly helpful to diagnose a recurrence in the breast earlier because that might be able to be surgically removed. The more complicated issue is it helpful to diagnose a recurrence in the bone, for example, that Shireen mentioned was the most common distant place. And actually, there is not data to show that diagnosing a recurrence in the bone earlier actually improves outcomes. And I know this is probably something that is hard to understand, but if cancer has spread to the bone, we want to treat it and we want to biopsy it, but it has already travelled there and we're not expecting to surgically remove that bone from the body. And the studies to date have not shown that finding it in the bone 2 weeks earlier by doing a scan when you had no symptoms at all is going to be helpful than if you developed pain and came in. So while when I was a junior oncologist, we used to do once a year or every 6 months, we just used to do these bone scans and chest x-rays, and we gave patients quite a lot of radiation from doing all those scans, but it wasn't actually shown to be helpful, and there's trials addressing that. However, we are doing research on this question because there are now different subtypes of breast cancer that are known about that perhaps weren't known about then. And one of the areas of active research that's going on is looking at circulating tumour DNA. That's one thing, and whether blood tests might be helpful. But to date, we don't have data that doing a blood test regularly is helpful, but that's the sort of research that we are looking at.
It's just absolutely fascinating. I find parts of that very surprising, and I guess it's all part of this sort of journey of knowledge, isn't it, as you acquire expertise about individual types of cancers, their behaviours and the recurrence of cancers. Shireen, I wonder what research is happening into preventing recurrence in other types of breast cancers, like triple negative.
Yeah, so my favourite research areas, of course, trying to develop new therapies to affect other types of breast cancer, particularly triple negative and the HER2 type. And my particular interest has been immunotherapy. So I'd just like to say this emphasises the importance of ongoing research and breast cancer trials, which is why we're here. Because in the last 10 years or so, the treatments that have come forward in breast cancer trials to look at reducing risk of breast cancer recurrence have been quite unbelievable. So the technology has advanced dramatically and it's accelerated, and we can create better drugs now which are really effective against the cancer, which means less side effects and increases our chances of cure. So particularly for triple negative, which can be very aggressive in some women, and particularly young women, there's new drugs called olaparib, which are PARP inhibitors. We also have immunotherapies, which has just been approved in the US. So immunotherapy is combined with chemotherapy. So you can imagine we're trying to kill breast cancer cells and then reactivate our immune system to try and get rid of the cells that might be in other parts of our body. As you can imagine, our immune system has been developed over a million years to get rid of virus and bacteria and parasites, and we can try and harness that to try and also get rid of breast cancer cells. But it needs some fine tuning because obviously your immune system has not seen the breast cancer because it's developed, right? So this has been an interplay between your immune system and the breast cancer. And when we can see the breast cancer, the cancer has kind of tipped the balance a bit. So these immune therapies kind of try to tip it back the other way. And lately we have new drugs called antibody drug conjugates. So recently on the PBS was a new drug approved called Trodelvy, and that's a new type of treatment, and we're going to be seeing a lot more of these chemotherapy drugs. And what it is, it's targeting chemotherapy directly to the tumour. So at the moment we give chemotherapy into the blood, and it kind of also it's very effective against breast cancer, but also gives us some of the side effects such as nausea and vomiting and hair loss, where some of these new medications are very potent. They can deliver 4 to 8 times a higher dose of chemotherapy directly to the cancer. So we get far more cancer kill and less side effects compared to what would have happened if we'd given that higher dose right to the patient.
It's so inspirational to hear you talk, Shireen, and it's really exciting to hear about all of those new frontiers. I wonder, are there novel ways that you're experimenting with to make it simpler to determine the risk of recurrence, like blood tests, biomarkers, and so on?
Yeah, so as Prue has mentioned, blood-based markers are a very active area of research because, as you can imagine, we're looking for cells in the bloodstream that might potentially lodge somewhere outside the breast. But at the moment, we really need to make that technology very sensitive to pick up microscopic cells. And also which cells are going to matter, right? Because as you can imagine, your immune system is kind of trying to deal with this at the same time. So you kind of want to give it a bit of a chance, but you don't want to let it go too late. So it's kind of a balance that we're trying to learn to strike. And the other thing that may be helpful is imaging. So highly sensitive imaging. So at the moment, we don't have these tests because with scans, we only can pick up things about 1 centimetre in size, and that's obviously too late to pick up a cancer at a cell level. So we're developing X-rays such as PET scans, MRIs that may be able to pick up something that's really, really tiny. But then again, it's going to require research to work out, you know, is that tiny little cell actually going to make a difference in the long term? So it's still a very active area of research.
Well, I think we've gathered a bit of a sense of this exciting geography of current undertakings and fields of inquiry, Shireen, and thank you for that. I wondered if I can just circle back to you, Prue, and to give us your view of where research is going in the future to prevent breast cancers from recurring.
Sorry, so we're talking about the research at the moment.
Where do you see research going in the future? I mean, what are the most exciting fields of enterprise
Yes, I think that the idea of trying to identify targets and trying to match treatments to particular targets of breast cancer and trying to have more individualized treatments is the way that we are progressively going. You know, previously breast cancer was kind of premenopausal women all got chemotherapy after surgery and postmenopausal women all got hormone therapy. That was when I was training. That was how we started out. And we're increasingly individualising treatment. It's, you know, being individualised to some extent according to age when we think about hormone treatment, but also according to the subtypes of cancer. And it's exciting, some of the research Shireen has been involved in, trying to think about how much the immune system is active in a patient's body, where you can look at the extent of tumour infiltrating lymphocytes or TILs, which might show that the body is already producing a good immune response. We hope in the future that we might be able to do clinical trials to see if some patients could have less chemotherapy because their immune system is already working well, and trying to find the patients where the cancer cells are biologically more aggressive, where we might need to add some of these newer drugs in. And I think, you know, we have a lot of exciting things happening. And this group, if we think of most of the major improvements that have happened in breast cancer drug treatments to reduce recurrence that have happened in recent decades, this trials group has been involved in many of those pivotal international trials. And so I think we can feel really proud to be involved in a group like this because we know that we are making a difference. You know, drugs for HER2 positive cancer, this group has studied drugs in soft and text, drugs for women with BRCA mutations, and I think increasingly we will be subdividing breast cancer in a far more individual way.
You know, it's listening to both of you speaking over the last 10 minutes it's just struck me just how exponential knowledge is. You know, it begets more knowledge and more detailed knowledge, right? And the theme of our discussion here tonight is really all about the more knowledge you have, the more powerful you are. And I'm going to circle back now to Leslie Stafford, just because we talked at the very beginning of this session about the topography of fear and anxiety that that tends to prey on people at various stages of their breast cancer journey. And but I wonder, we've got so many questions about the practicalities of how to address that fear when you're in the grip of it, Leslie. And Alex in particular has asked the question of what you can do to reduce anxiety specifically about recurrence.
It's the magic question, isn't it? And I guess the good news is that there is actually quite a bit of research evidence showing that the treatments that we offer do work, so you don't just have to take my word for it. I'll just say quickly on a very practical level, some of the ways you can take back some control in a sort of sea of uncertainty is to, to have a plan. So, very simply, ask your doctor what you can do about preventing recurrence, what is within your control. Have a very clear idea of the type of surveillance you need and how often you need it. Because knowledge and information allows you to manage your expectations a lot better. So find out what sort of symptoms you need to look out for, what is a problem, what isn't a problem. So that's just on a very practical level. On a more psychological level, fear of cancer recurrence is maintained by a cycle of thoughts, feelings and behaviours and physical sensations. And we found that the sort of contemporary cognitive behaviour therapies work really well, because what we're doing is we're helping people to learn new skills about the presence of these sort of difficult thoughts or feelings or sensations, and sort of teaching them to be less caught up with those worries about recurrence, giving them less attention. So the focus is a bit more on how you live with these thoughts and feelings, how you accommodate them, even if they're painful, rather than trying to change them or get rid of them. And one particularly helpful approach is acceptance and commitment therapy, or ACT. And ACT is about, I guess, helping you to stop struggling with your thoughts, but to notice your thinking. And as you know, I could go on endlessly about it, but I think I'll leave it there.
Well, I think anxiety, the more that we understand it, we understand that it's a cycle, right? And anything that we can do to disrupt the cycle or to introduce tools that help us to recognize what's going on and accept it and then move on. There's a lot of people that have entered questions for this session who have talked about the phenomenon of scanxiety, which is a feeling of anxiety at the regular markers of the experience. Every time you have an appointment or a checkup or a scan, you have a mounting sense of anxiety beforehand. Do you have advice specifically on how to deal with that and manage this obligation to have those necessary checkups?
Yeah. So look, scanxiety is a big issue. I've heard it referred to as one's date with your digital destiny. And sort of often, women notice that they're tearful and anxious, but don't sort of realise why, and then it dawns on them that it's because there's a scan. It's an anniversary of a diagnosis. So, and it's not just that period leading up to the scan, there's also their period waiting for the scan results. And look, I guess it's so frustrating for women and their families that often, there's no evidence of disease on the scans, but they're not reassured. And, Leslie Gillum was saying that her GP had not been concerned and had sent her for a scan for reassurance, and then there was something. So women really struggle sometimes to be reassured by the scans. So, I would say when you're thinking about scans, remember that worrying can be a habit. Ask yourself, is worrying about this really going to help me in some way? Is it going to help me to control the outcome of the scan? And some of us think worry is important. We think that the more we worry about something, the more we'll be prepared for it to happen. When it happens, we'll be more prepared for it, is what I mean. But of course, that's not the case. When we worry about something, we actually just start to fuse with that thought. We get really connected with it. We struggle with it. And so what I often recommend for women is that in the lead up to your scan, set aside half an hour every day, sort of later in the day, to fully focus on your anxiety. And when your anxiety pops up during the day, just say, no, I'm not worrying about you now. You are going to my designated worry time. So you teach yourself to postpone the worry to later on. And this also sort of shows women that you can flexibly move your attention if you want to. Another idea to manage scanxiety is exercise, and I know many will probably be groaning inwardly at the mention of this, but it is one of the simplest and most effective ways to reduce stress and anxiety. I'd also say acknowledge your worries and become more aware of how you as an individual react to stress. So if you know that when you're stressed, for example, your breathing becomes shallower or your hands become sweaty or you're clenching, then you can identify that more quickly, and if you learn relaxation methods or guided meditation or visualization, you can implement those strategies when you notice that you're clenching or sweating or breathing shallowly.
Thank you. I'm also thrilled at the idea of putting things off to a worry slot at the end of the day. My worry slot is about 3:30 a.m. I just always manage to pop awake in order to have a good old fret uninterruptedly in the wee hours of the morning. Very, very healthy. I'm going to go to Leslie Gillum in a second, but I just wondered, Leslie Stafford, you talked about resources, and I wondered if you could just quick fire if there are any kind of good places to start when looking for support services specifically around this fear of recurrence.
I guess that the type of support service that you want would be dependent on how severe your fears are. So I think for most people, it's probably enough to get a bit of education and to get a bit of support from peers or peer support or advocacy organisations. So, for example, Breast Cancer Network of Australia have a series of short videos on fears of cancer recurrence. They have a fact sheet. They also have quite an extensive online network where you can connect with people who've experienced their stories, have experienced breast cancer, and with whom you can share a story or learn from. Another sort of quick tip is most of the major cancer centres internationally have evidence-based tip sheets on fear of cancer recurrence that you could search for in any search engine. Beyond that, one can always call the Cancer Council Information and Support Line on 131120 for advice and support. But if you're, if your fears are disabling for you, they're really disrupting your everyday activities, you're checking excessively, your family or friends are worried about you, then I really would suggest going to see your GP. And your GP may refer you to a counsellor or a psychologist in the community, and you can do that under a mental health care plan. And I think that's really important to do, to seek professional clinical help if your distress is persistent. I guess the only other thing is that if you're still connected with your treatment centre, and many people aren't at the stage that their fears become quite obvious, you can always go back and have a good discussion with your breast care nurse if you have access to one, with your medical oncologist, and they can sometimes also have referrals available to social workers or psychologists on site.
Thank you, Leslie A. Leslie B, I'm going to go to you for a first-person account now of this experience for you. Rochelle has used such an evocative term in addressing her question. She says, how do you avoid the paranoia monster? How do you stop worrying about any ache or twinge that you feel? How have you managed, Leslie, to live with the fear of breast cancer coming back, and does it get any easier?
Well, thank you, Rochelle. I guess there's a fine line between being paranoid or being proactive when it comes to your health. So I guess participating in a trial for me, I had that extra reassurance in the initial stages, but then, as I mentioned previously, once you leave your treatment team, you do tend to be a bit more on your own, and you know, the slightest twinge can become something in your mind that you think is something worse than it is. So I guess from my personal perspective, I think I'll take proactive over paranoia. So I utilise the time during my treatment phase, and also probably, or at least 3 or 4 years afterwards, to I guess engage with my GP, get referrals to appropriate clinicians that could help me with some of the side effects and set up sort of like, I guess, baseline things like for cardiac issues or things like that. So that sort of has helped me, I guess, focus on things I can control and things I can't control. So, you know, I can control how I look after my heart health and things like that. So I think there's certain things that you can do to be proactive. In saying that, you know, there's, you know, you might wake up in the middle of the night with an ache somewhere that you haven't had before. So you sort of, then that sort of triggers that fear, I guess. So, you know, I guess GPs are probably a first port of call, but, you know, as Leslie S mentioned, you can then go back to your oncologist if you do have any lingering concerns. But yeah, I guess it's just a matter of managing those triggers and moving on. I don't know, it does get a little bit easier because I think you actually, because the further away from your diagnosis you get, the better you are at your coping mechanisms, in my perspective. So I think Leslie mentioned, you know, putting it in the worry slot. I have a saying that I won't repeat here, but I have a saying that when I do have a negative thought, I have this saying that then puts me back in the moment and gets rid of that negative thought. So I think my husband's always been my rock in this space. He always says, don't worry about things you can't change, only control the controllables. And that's been sort of, I guess, my my thing that I've stuck throughout the process. And I guess the one thing that I draw on the most is probably because of my involvement with BCT. I see the amount of work that people like Prue and Shireen are doing in this space, and that reassures me that even, you know, if I was unfortunate enough to have a recurrence, you know, the amount of work that's being done is reassuring that it doesn't necessarily mean that it's not going to be treatable. So I guess that's just from a personal perspective, that's what I draw on.
Great. Look, we're about to go into our final run of questions to Shireen and Prue, but like I wanted to quickly ask you, Leslie, I'm aware that some of the people on this feed tonight will be family members who are caring for people that they love who are going through this. And I just wanted to ask you how your families coped watching you and being with you as you go through all of these stages and these milestones in 5 and 10 years with no recurrence, and how have you had family conversations about recurrence? Obviously your husband is good at telling you to be aware of what you can control and what you can't, but what about others in the family?
So I've got 2 children who were in their early teens at the time of my diagnosis, so they're obviously a lot older now, but all of them have been extremely supportive. I didn't mention earlier, I was diagnosed, and then 6 months later my sister was diagnosed, and then upon investigation, turns out my dad actually had breast cancer, but we're not BRCA, so we're sort of in a bit of limbo there. But so I've had like quite a strong support network around me just through multiple diagnoses, I guess, and all being involved. So, but I guess that when I was diagnosed, I was a bit of an open book with my immediate family, so I involved them in the whole process. So I demystified the treatments with the kids, so they came along to my different things, so they understood what was taking place. I guess from my perspective, one of the worst things was actually letting them take care of me, because you're used to taking care of them. So, but they've been there throughout the whole journey, I guess, like from the initial diagnosis, having to deal with my side effects, especially that instant menopause, and just that constant reminder. But I guess I'm still open with them. So when it comes up, we were talking about scan anxiety before, I let them know that I'm coming up for a scan, and, you know, with my daughter in particular, whether she wants to come along or whatever. And then they can then touch base with me about how it went and that sort of thing. But I think together we sort of managed to get through the worst of the times, and while it's still there, we sort of, I guess, are a lot closer and much more supportive as a whole. So I think we're very fortunate and grateful for the research because, as I think it was Prue mentioned, when she was just starting out in her career, my outcome might not have been as good if I was diagnosed back then. So we're very grateful for everything that the researchers have done and BCT.
Yeah, the trajectory really is extraordinary, and it's very good of you to share your experience and, of course, your commitment to research as well. I know that we're all busy and we're coming towards the end of our time. I'm determined to smash through as many questions that remain to Shireen and Prue in particular. So I'm going to be merciless and smash through them because I know that everybody's out there is thirsty for information. Shireen, you first. Several people have asked whether there's a difference in recurrence rates for people who have a mastectomy compared to people who have a lumpectomy. And is it better to prevent breast cancer recurrence by removing all breast tissue?
Yeah. So thank you for that question. This is a very common question and a source of anxiety for women who've just been diagnosed and, they want to remove both breasts or one breast, or the bottom line is if you have a small cancer that can be removed with a lumpectomy and radiation, then there is no difference by having a lumpectomy, radiation or mastectomy. Of course, we like to steer away from a mastectomy because that can be, obviously bad for one's self-image, and reconstruction is not a minor surgery, and often there are problems with reconstruction. So if we can get away with breast conservation, we would certainly recommend that. For women that have a genetic abnormality found in their blood, then of course the conversation is different because they have a much higher risk of breast cancer coming back in one breast or the other breast. Other things that may affect mastectomy versus breast conservation is size of the breast cancer as well, and if there's a lot of surrounding DCIS. So there are many factors, but certainly we do not recommend to have a mastectomy unless there's clear life extension from that treatment or reduction in risk.
Okay, all right, let me bowl you up. Cynthia's question, she wants to know what are the best methods for monitoring and detecting recurrence, and should these involve PET or MRI scans, particularly if you have a history of breast cancer?
So generally at the moment, once you've undergone your surgery and treatment, we do not recommend extensive imaging such as PET or CT scans. We do recommend imaging of your breast because we can deal with that very effectively, but we do not have the methods at the moment to pick up cancers that come back outside the breast very effectively. And of course, having lots of scans increases your radiation risk, so we don't recommend that. We may have something in the future, but we certainly don't recommend that now unless you have a clear risk for increased breast cancer recurrence in your breast. So that's where we look. That's very anxiety provoking for a lot of women. But as I said before, we try to let your body look after itself, and not scans can cause a lot of worry, of course. So this is why we don't do it.
The dreaded scanxiety. Thank you. You're doing brilliantly in the rapid fire round. Thank you, Shireen. To Sharon now, who asks, is there any pattern of recurrence according to previous treatment regimens?
No, I would say that if you're compliant, if you do what is recommended, so have your radiation, your surgery and your treatment, then there's generally no logical reason about where or if a breast cancer recurrence will come back. So no, we can't predict these things. We don't really have a crystal ball, unfortunately, at this point.
Okay, now we heard Leslie earlier say turn off social media. It's not very helpful, but we also know from this discussion that, knowledge is our friend. The question coming up, I reckon would get a big gallop on social media, and the anxious midnight Googler would find a lot of references to this. So this is why it's a good idea to put it to you to let us know how much connection there is here. A lot of people have asked, what about stress? Is there any research that suggests that stress can cause a recurrence?
So the bottom line is no, there is no strong research that stress has anything to do with a breast cancer recurrence. But as Leslie says, that can obviously affect how you live your life, and some people can have quite severe anxiety about their breast cancer recurrence. I think, as Leslie says, the most important thing is to control what you can control. So try to control your reactions. You can do lots of positive things, such as Leslie's been doing, but also just simple things such as, exercise. We know greater than 7,000 steps a day is beneficial, and for younger women, high intensity is better. Keep your weight at what it should be, reduce your alcohol intake, and, have a healthy diet. So all those things you can control. You can be fit and healthy, and we know that being fit and healthy reduces your risk of recurrence and also of other diseases and illnesses as well. So that's the best thing you can do for yourself and your body, and also for your breast cancer risk.
Thank you, Shireen. We did have a question from Amber actually asking if there was any scientific research about the healthiest dietary choice to reduce your change of recurrence. I'm intuiting from your reply, Shireen, that it's not really a specific thing. It's a general, keep yourself in the healthiest shape that you can, just as a general rule, apart from anything else. Prue, I'd like to bring you in now and ask if you've got any observations to make about dietary choices, specifically vis-a-vis the risk of recurrence.
Yes, so I don't think there's a magical diet. I think that a diet that is generally one that reduces the risk of developing not only breast cancer, but other types of cancer, because actually, interestingly, many women who develop early breast cancer in the next 30 years actually have a higher chance of getting a new non-breast cancer, for example, a bowel cancer or some other type of cancer, than they actually have of getting a recurrence of breast cancer. And there's probably about 13 different types of cancer, including breast cancer in postmenopausal women, that is actually influenced, for example, by being obese or having a very high body mass index. So trying to optimize weight is a good thing, obviously from the heart point of view, but trying to reduce the chance of perhaps getting down the track, a cancer of the uterus or a cancer in the bowel or some other organ that is influenced by, the kidney, by diet. So really trying to get a diet that's got, lots of grains and legumes, and healthy foods, trying to avoid a lot of the unhealthy meats. For example, the smoked meats are not good for gastrointestinal tract cancers. Lots of vegetables, fruit, and trying to avoid a lot of charred red meat. That sort of barbecue meat should be more of a treat rather than everyday meat. But you don't have to be a vegan or a vegetarian, but trying to keep your body weight at a good level or to head in that direction without beating yourself up if it's slow.
What about keto diets? People talk about that a little bit.
Yeah, I don't think there's anything magical about paleo or keto or anything. The one diet that's not good is the lockdown diet, which involves sitting at your desk, eating a lot of food and drinking a lot of wine.
Oh, Prue, that's my diet.
Well, unfortunately, we do know that alcohol is a risk factor for developing breast cancer. And we know that women who've had one early breast cancer will be at slightly higher risk than the average person in the population of perhaps in the rest of their life getting another breast cancer. So trying to have plenty of alcohol-free days as well as those special days where we enjoy alcohol.
Sure, and cutting back on the alcohol also makes that worry slot a bit easier to navigate. Nearly running out of time now, but I just wanted quickly to put to you Alicia's question, because we've done exercise, we've talked about diet, but Alicia wants to know if there's any evidence at all for holistic treatments and adjunct therapies in addition to medical treatment, such as acupuncture, specifically to this issue of recurrence.
So I would say that adjunctive or holistic or complementary therapies can certainly be helpful to women in helping them to cope with the other medical, surgical, radiation treatments, hormone treatments that their doctors are recommending. So because they can help you cope with side effects, help your headspace, they can help your relaxation, and you may be more able to comply. For example, we know that women who are able to comply or adhere to the endocrine or hormone therapy that's recommended have a lower risk of recurrence. And so those complementary holistic things, if they can support you to cope with the hot flushes or the sleeplessness or, you know, the other things, and will allow you to complete your treatment, in that sense, indirectly, they can reduce recurrence by allowing you and supporting you to adhere or persist with difficult treatment and side effects. I don't think they do it directly.
Right. Okay. Great. Now, I know that you've had an incredibly long day, Prue, and I have rather viciously left the biggest question that everybody wants answered right to the end of the session. So thank you for your mental acuity after a busy and long day at work. The big question that so many people have asked is, what are the signs and symptoms we should look for to determine whether breast cancer may have come back?
So I think, you know, symptoms that we will sometimes find patients have developed would be things like a lump, an unexplained lump, or perhaps persistent unexplained pain. However, I would point out that sometimes when you have your COVID vaccine, you may get a big lump under your arm for a while. So not all lumps are cancer recurrence. And the other thing is, if you think of anybody who doesn't have breast cancer or who does, over the next 10 or 15 years, we are all going to get body pain. We are all going to have a sore knee. We are all going to have a sore back. We're going to have a frozen shoulder, something. So most pains in people who've had breast cancer are not going to be a recurrence of breast cancer. But if you have persistent, unexplained pain in an area, then it's good to touch base perhaps with your GP, perhaps your previous breast nurse or one of your treating team to understand whether this is a pain that they recognise as not being sinister versus one that possibly could be sinister. We know that joint pain is very rarely related to breast cancer recurrence, for example, sore knees, you know, that's not very unlikely to be breast cancer recurrence.
Look, I know from the Australia Talk studies that we've done at the ABC that there is a really strong pattern of women who have had experiences in the past of having some of their concerns brushed over a bit by some encounters they've had with GPs. And there is a tendency among some women to feel bad about wasting people's time with something that might be nothing. Now, you're an oncologist, you're at the end of these sorts of inquiries and at the end of these anxieties. Can you reassure women listening that then how do you all feel about people frantically coming in the middle of a panic attack about a lump or an ache?
Well, we're certainly, you know, when a woman is discharged from an oncologist, we're certainly happy to see them in the future if that's indicated. You know, sometimes just touching base with your previous breast nurse, if you feel that the GP is not giving you the answers that you feel confident about, or you want some more reassurance, perhaps touching base with your breast nurse, your surgeon, your medical oncologist. You know, we're happy to be recontacted when people, you know, you're always our patient, even if you're never coming booked to see us again. So we're always there for people and happy to deal with concerns. But remember, most things that happen will not be cancer recurrence. But if you have something that's persistent and unexplained, then certainly feel free to get in touch with your treating team.
Great. Look, we are out of time. I know that everybody's busy, and I'm really grateful to all four of you and also the 2,800 joining us remotely for setting aside 90 minutes of time to talk about these issues. I think I don't think I'll forget Leslie's account of the first day being the hardest. So I'm very conscious of those joining us here who are at day one or close to day one. And I hope that this panoply of information and expertise on show this evening and personal experience might help to escalate your path along the journey from day one into a better and more calm and anxiety and disease-free life. So for all of us here on the panel, I'd like to just extend our very best wishes to everyone joining us, wherever you are on that journey or whomever you're on that journey with. And most particularly, I'd like to thank our panel participants, Leslie Gillum, Shireen Loy, Prue Francis, and Leslie Stafford, thank you for providing some guidance along this path from fear and ignorance to peace of mind. So good luck to all of you with your worry slots. Make sure you park everything in them and as far as possible, enjoy everything else that's going on in your life. Thank you so much for joining me. I feel like I learn an enormous amount every time I participate in one of these, and I'm constantly humbled by the degree of application and expertise in this field of science and medicine that you all inhabit. And thank you also to Breast Cancer Trials for the consistent attention to and quest for knowledge in this such a crucial field. Thank you all and good night.